Good evening, everyone, and welcome to the Alaska Eating Disorders Fall 2023 Project Echo. My name is Beth Rose. My pronouns are she, her, and I'm one of the co-founders of the Alaska Eating Disorders Alliance. We're very excited to see all of you here this evening. A little technical difficulty. Tonight's Echo session offers a forum for Alaskan interdisciplinary healthcare professionals to connect with eating disorder experts and with each other. We will have 4 sessions this fall, held every other Thursday evening. Each session will include a didactic presentation on a key eating disorder topic from a subject matter expert, a time for a Q&A, and a case presentation from a local provider with the opportunity for you to engage and learn from other professionals in the field. This series has been guided by a hub team of professionals and experts in eating disorders. They will introduce themselves in the chat box if they haven't already, and I actually might encourage them to do so for people who came earlier and may not have seen your names. Our series has been approved for continuing education units, and participants can claim 1.5 credit hours per session of this Echo series. In order to claim credits, you must attend the live session for at least 90% of the full session time and complete an evaluation form, after which you'll be redirected to receive and download confirmation of your continuing education credit. At the end of our session today, a link to that evaluation will be provided in the chat box. I encourage all participants to fill out the survey, as it tells us how we're doing and how we can improve. And so before we jump in, just a few Zoom reminders. Closed captions are automatically generated and available by pressing the CC button at the bottom of your Zoom screen. Please take a moment to turn on your camera so that we can all get to know each other. The camera icon is on the lower left of your screen. Please keep your mic muted during our presentations, and when you are not speaking, you can mute and unmute yourself easily by clicking on the microphone icon on the lower left of the screen. Engagement with the group is integral to the all teach, all learn philosophy that underpins this Echo program. We encourage everyone to ask questions and make comments during the session by utilizing the chat box, or when appropriate during the Q&A session by unmuting yourself and sharing directly with the group. You're also welcome to privately chat the session host, me, or any members of the hub team if you'd like your question shared anonymously. It's helpful to get to know each other, so if you haven't done so already, please introduce yourself in the chat box by sharing your name, role, organization, where you're coming from, and if you'd like to share what you'd like to get out of this Echo. If you're a hub team member, again, we ask you to introduce yourself as a hub member as well. Please note that the opinions of the hub team and presenters are their own and do not necessarily represent those of Akita or any Echo sponsor. And Project Echo is not HIPAA compliant. Therefore, no protected health information is to be shared or displayed at any time. Thank you to everyone for following these guidelines. And finally, I'd like to pause for a brief moment for a land acknowledgement. And although this is a virtual space, our Echo team is joining you from Anchorage. And as such, we want to thank the Dena'ina people for their stewardship of the lands, water, air, and all life that sustains us within the traditional lands of the Takatanu Cook Inlet region. We respect the Dena'ina cultural ways and their homelands and shall strive to be good neighbors. Now I'll turn the session over to Akita's Executive Director, Becca Kurian, to share a bit about the vision that's driving this initiative, the purpose of our Echo, what's on today's agenda, and some reminders about best practices and language when engaging in today's discussion.
Thanks, Beth. I'm Becca Kurian, the Executive Director of Alaska Eating Disorders Alliance, and I'm thrilled to welcome you all this evening. The goal of this Project Echo is to work together to grow capacity within our local healthcare system to better understand, diagnose, and treat eating disorders in Alaska. During our time together, we'll be learning through the presentations and discussions, and we want to be mindful of creating a welcoming learning community. Words matter, and they are powerful. This is an open space where all voices and bodies are welcome. We encourage you to seek ways to use inclusive, non-stigmatizing language. Let me start with a broad outline of this evening's agenda. We will begin with a presentation by Amy Pershing titled Unraveling the Truth About Binge Eating Disorder. Amy is a licensed master social worker who is one of the preeminent experts in the world on binge eating disorder. She is the founding director of BodyWise, a comprehensive treatment program for binge eating disorder, and a clinical director of the Center for Eating Disorders in Michigan. She's also the founder of HungerWise, a 10-week program for ending chronic dieting and weight cycling. She lectures internationally on binge eating disorder and is the author of the book Binge Eating Disorder, The Journey to Recovery and Beyond. In addition, she was active with the Binge Eating Disorder Association, which honored her with an award as a pioneer in clinical advocacy. After the presentation, Amy will lead Q&A with our participants. Our session will conclude with a case presentation by Irene Saxon. Without further ado, I'll pass the session over to Amy to share our didactic presentation.
Thank you so much. What a lovely, lovely welcome. Thank you. I'm going to switch over to my slides here, and we'll get started. And again, thank you for welcoming me. I really appreciate it, and I'm delighted to be able to talk about binge eating disorder with you this evening. I know I'm going to start my timer here so I can pay close attention. I know we have just about 40 minutes. And so what I want to do is I'm going to talk fast, and I'm going to get as much information into that 40 minutes as I can. I've put a lot of the information, basically a lot of what I'm going to say is already on the slides. So you'll have that information available, and we'll go through them quickly. And then if you have more questions, we can get to that at the end of the presentation. So let me just start with, again, part of what I'm excited about in talking about BED is that BED is by far the most common eating disorder. We're going to talk more about the statistics here in a little bit. And it is, but as the most common, it's also the least taught in terms of treatment. And so today, a lot of what we're going to talk about is really what clinicians need to know to treat BED in particular. We're going to look at some of the assumptions that many people still really hold about the disorder. We'll look at the training that you really need to treat BED effectively. One thing I want to say too is that I do have some quotes from my clients woven throughout the presentation. I use those quotes with permission, and I just want to honor my clients for being willing to share their stories a bit. Oops. So fundamentally, I think our work as therapists is to help our clients more fully understand their relationship with food. But we need to do that from a place of compassion. We need to understand that that relationship with food always exists for good reasons. And we also need to understand that our clients have profound ambivalence to change. Changing these patterns is extremely difficult. So our job is to help clients expand their toolbox in terms of strategies to help stay safe, and also to help them create an inner world that's a compassionate place to be. So I start with these two quotes because I think they're just very powerful about just how important that relationship with food is for our clients' survival. For me, binge eating was the one thing that was completely mine. When I first entered treatment, I felt two very different things. Part of me was ready to change. The other part was very clearly saying, no way am I doing what I'm supposed to do. I nearly died doing that my whole childhood. And I do know there are times I eat when I'm angry or when I feel self-loathing, knowing I'm not healthy, that I'm struggling with prediabetes, with autoimmune issues, with food allergies, with high cholesterol, and I binge anyway, in spite of it, to spite myself, to spite life, to spite God, to make it worse, because I feel so bad. And sometimes feeling worse kind of helps me express the anger. So just from those quotes, I think it speaks to how important this relationship with food feels to our clients. So let me start just quickly going through the definition of binge eating disorder, the clinical definition. These criteria are very much about a starting point and a compromise. They're the basis that have allowed us to create a diagnosis. I was lucky enough to be a part of the group of folks that put these criteria together to get into the DSM. But I say that also to say that these criteria really are about getting a diagnosis so that we can get insurance coverage for when we can, and for research dollars to be available. This diagnosis is not meant to be inclusive of everyone who walks into our office with BED. So I'm going to kind of say a few of those caveats as we go through the definition. And the first one is going to start with a caveat. So recurrent episodes of binge eating, which means eating in a discrete period of time, approximately 2 hours, an amount of food larger than most people would eat in a similar period under similar circumstances. The caveat is that amount of time. For some clients, it may be throughout the day, and it looks more like grazing than it looks like a short amount of time in a binge, what we think of as a binge. A sense of lack of control over the eating during the episode, that is one of the most important clinical components. The amount of food or the time that the binge lasts is much less important than that sense of feeling unable to stop the behavior, even though there's a strong desire to do so. Binge eating episodes are associated with at least 3 of the following: eating more rapidly than normal, certainly very common, but not always. Eating until feeling uncomfortably full, common, but not always. Eating large amounts of food when not hungry. The person may or may not start that binge cycle when they're feeling hungry. Secretive eating, of course, very common, but people can binge very publicly. And you may not know that they're sitting across from you actually binge eating. And then the last one, feeling disgusted, depressed, or guilty after a binge, that is absolutely also hallmark. So that loss of control and that feeling disgusted, depressed, or guilty after a binge are really the most important criteria. Binge eating occurs on average 1 day per week for at least 3 months. Again, that can vary a great deal. Disturbance does not occur exclusively during the course of anorexia or bulimia, because both of those disorders can also have binging as a feature. Some things I add in addition that are not part of the clinical diagnosis: significant body dysmorphia, shame, and weight or shape obsession is very common. Not always the case, but certainly very common. May include significant restriction of food intake and/or types of food consumed. BED is a disorder of restriction. The vast majority of the time, we will see significant restriction behaviors in our clients, as well as binging. People of all sizes and shapes can meet diagnostic criteria. You cannot tell by looking at someone if they have BED. People with BED who deal with BED come in every shape and size. BED is typically, as I said, a disorder of restriction. So one thing to keep in mind diagnostically, and we'll talk about screening for this toward the end of today. Many people may also meet the diagnostic criteria for atypical anorexia, which means they don't meet the weight threshold or have met diagnostic criteria for anorexia previously. So the statistics are really frightening. BED affects approximately 9% of the general population. That's 27 million people. So it is a very, very common relationship with food. So we're going to see this a lot in our clients. It's the most common eating disorder by 5 times. It's more common than breast cancer or HIV or schizophrenia. It affects the largest number of men of any of the eating disorders by far. It's also the most underdiagnosed eating disorder. People with BED are still going, it's getting better for sure, but folks are still going into their, primary care doc's office and getting prescribed a diet. So we're still not necessarily seeing people labeling that relationship with food as an eating disorder, but again, it is getting better. Another statistic I think is just really important. Up to 70% of people seeking weight loss surgery have clinical binge eating disorder. So we are seeing most folks who are going in to get weight loss surgeries have active eating disorders. There are a number of comorbidities with binge eating disorder. Some of these are, we don't know whether it's a causal link or what the links necessarily are, but there are many of them. I just have listed them here. They're not in any particular order, but a few of them I think are worth particularly focusing on. Type 2 diabetes, of course, is a common one, and there are a number in here, but metabolic changes, which I'm going to talk about a little bit more in just a minute, are important. Also ADHD. About 30% of folks with BED also could have an ADHD diagnosis. So there are some particular interventions in working with BED and ADHD that change the treatment a little bit. We're not going to have much chance to get to talk about that today, but I think there will be more of that coming along. I'm doing a second edition of my book, and that's going to be a lot more information in there as well. So if you have questions about it, please feel free to connect with me. Anxiety, sleep apnea, PCOS is very common. Also important to see to think about our nutritional deficiencies and the side effects of starvation. We don't tend to think about that as potentials for binge eating disorder, but indeed they very much are. So we want to be paying attention to some of those symptoms as well. So BED is correlated with something called metabolic syndrome, which is a constellation of symptoms that include high blood pressure, high blood sugar, higher amounts of body fat around the waist, and abnormal cholesterol levels. BED may or may not be causal for these conditions. So we also want to keep in mind that at any given person, we're looking at genetics, epigenetics, and environment are also going to be playing a role. So we have to take a look, obviously, at person and environment. Correlation with body size does not equal causation. So we can have metabolically healthy fat bodies and we can have metabolically unhealthy thin bodies. So again, we can't make assumptions based on body size. Metabolism is also impacted by dietary restriction and binging. So, and we'll talk more about this, but treatment cannot prescribe dietary restriction. And we'll talk a lot more about why that is as we go on a little bit more. With etiology and co-occurring concerns with BED, there are many. So if people come into your office with binging behavior, they very likely have a whole lot more going on behind that. So BED has the highest rates of trauma of any of the eating disorders, including sexual abuse, physical abuse, neglect, early loss, and greater situational trauma. We're going to talk a little bit more about that in a minute. Higher rates of developmental and attachment trauma in family of origin. Also higher rates of substance use disorders in family of origin than other eating disorders. Significant rates of co-occurring mood disorders. Families often have significant difficulty with affect tolerance, significant social anxiety, and some of that can be about weight shame and weight stigma, depending on the person. Significant histories, as I mentioned, of dieting and restriction. Very high rates of weight-related bullying and weight stigmatizing experiences. There are a number of studies, ranges from about 60% to up to 90% of folks with who are diagnosed with BED saying weight-related bullying, they feel directly contributed to the development of their eating disorder. So very high rates of bullying and early childhood trauma through that bullying, and high rates of previously meeting diagnostic criteria for other eating disorders, including anorexia and bulimia. And just a few of the pieces of research that speak to the rates of trauma, I think just kind of drive that point home and are valuable to just take a look. 74% of about 300 women attending residential treatment with binge behavior indicated that they had experienced a significant trauma. 52% reported symptoms consistent with a diagnosis of current complex post-traumatic stress disorder. These symptoms are far less correlated with restriction behaviors without binge eating. So again, when you're seeing binging, you're seeing trauma is a pretty good guess. A total of 83% of BED patients reported some form of childhood maltreatment, 59 emotional abuse, 36 physical abuse, 30% sexual abuse, 30% sexual abuse. That's very high. 69% reported emotional neglect, 49% physical neglect. Emotional neglect was the most frequent event experienced in cases where binge eating was present. And then the last one, participants with 3 or more ACEs, that's the adverse childhood experiences, had nearly 9 times higher odds of developing BED at a 2-year follow-up. Of the different types of ACEs, household mental illness, household violence, and having a criminal household member were most strongly associated with BED. So person and environment is extremely important in treating BED. Another quote from my client, Allison. I was 5 when my stepfather sexually abused me. I needed him in my life so badly, and my mom did too. We couldn't afford the rent without him. I remember clinging to him, begging him not to leave, despite what he did to me. I felt like a loser my whole life because I begged him to stay. What kind of freak wants their abuser to stay? What I didn't realize is that I was still shaming myself for what he did to me. He is still off the hook, and I'm always in the wrong. Now I know I had no other choice but to blame myself and my body. So as I mentioned, many of these co-occurring experiences of co-occurring trauma have a profound impact on the body. And of course, that is also very much a driver of binge eating. So a lot of the symptoms we see with our clients who have trauma histories and BED, we see things that often we think of as autoimmune disorders as well. Extreme fatigue, chronic pain, muscle tension, and freeze or flight sensations, disconnection from basic somatic cues. And of course, this one is particularly important in treatment, helping clients reconnect safely to their bodies. But many of our clients, when they come in, are not connected to hunger or fullness or pain or arousal because it was dangerous to be connected to their bodies. Many of my clients, when they come in, are either on a diet or off a diet, but they really don't have any idea about how to eat based on their body. Insomnia or sleep problems, immune system problems, GI problems, anger or outbursts or significant experiences of agitation, numbness or dissociative symptoms, blunted or extreme affect. We can see either end of the spectrum, a sense of confusion or inability to focus attention, and sometimes hyper-focused attention. And again, some of that can be about also a co-occurring ADHD diagnosis. But we can see how binge eating, and we're going to talk a little bit about chemically how that may actually work, but can soothe a lot of these symptoms. So we're going to talk more about that. For many of the clients that we see, the dangers are not in the past, but they're in fact still very much a part of their lives. So we might see effects of legacy trauma. So that is clients who are kind of waiting for that other shoe to drop. And that's very much been their lived experience. Obviously also the effects of racism, anti-Semitism, poverty, homophobia, misogyny, gender bias, rape culture and objectification, transphobia, ableism, classism, all of those things can very much be part and parcel of our clients' lived experience right now. A current sense of uncertainty, I'm assuming you are as well. Many of my clients are scared. They're just scared about the nature of the world right now. Political unrest, climate change, psychological impact of COVID, poor healthcare, concerns about their financial future. I mean, the list goes on and on. So I think, as we know, the work of therapy is not to help people adjust to oppression. So also part of the work in helping our clients heal from their eating disorders is going to be helping them find ways to deal with, as best we can, the environments in which they find themselves today, not just the past. I also put weight stigma in that category, and I gave it its own slide. But bottom line is weight stigma is still a socially sanctioned form of oppression. It is abusive. It means bodies are judged, commodified, and seen as worthy only if they fit in a certain shape or size. So it's the definition of weight stigma is the discrimination toward people based on their body weight and size. It promotes the assumption that all bodies are thin naturally and that being fat is an inherent state of pathology, typically due to overeating or lack of exercise or poor willpower. Right, so there's that fundamental supposition that thin is reasonable for all bodies, and that if a body isn't thin, something's wrong. Clients in larger bodies are often fat shamed, bullied, and discriminated against in many settings, including healthcare, education, and hiring practices. And there's a lot of data that supports that. Body shame is easily internalized for survivors of other kinds of trauma in particular, right? Because there's already a narrative that I'm not good enough or there's something wrong with me. So it's fertile ground. It's very difficult for clients to fight back against weight stigma. There's rarely a questioning of body shame as normative, right? As normative. In our culture, it's normal to hate your body, even if you don't have an eating disorder, right? Or without trauma. It's very unusual for people in our society, particularly women, to just be at peace with their bodies. We expect it as normal. So internalized weight stigma drives binge eating and normalizes body shame. One of my clients said it this way: I don't live in my body, I monitor it. I monitor it, and that is a direct result of weight stigma. So any treatment, bottom line, has to involve treating weight stigma. We'll talk a little bit more about that in a minute. So I just want to talk quickly about why the behavior of binge eating actually may be effective. In fact, why it works. I share this information with my clients, and in fact, I find them a lot of, oh, okay, that it really does make sense. I'm not crazy. I'm not broken. There's not something wrong with me. There's chemical stuff going on here. So I find this information just to be very useful for clients. So the link that it's not fully known or understood which of these things are true, if they're true across the board, or if they differ from person to person. But starting off, some studies suggest that cravings for food high in sugar and fat may be connected to higher levels of cortisol production associated with ongoing stress. So those foods seem to lower the production of cortisol short term. Unclear why that might be, but there does seem to be a connection there. So it really does, if you eat higher fat and sugar foods, make you feel calmer in the moment. So that's one possibility. Another one is dopamine surge is associated with highly palatable foods. And that may be driven also by a diet mentality with food. If those foods are particularly forbidden, that actually increases the hit of dopamine. And there are some really interesting studies that also look at people eating foods and the levels of dopamine that are people eating foods that they're okay eating and what that dopamine is like, and people eating foods that they're not allowed to eat on their diets. And we see it's an even bigger hit actually of dopamine. An increase in ghrelin, which is the hunger hormone, is produced during stress. So that may actually make eating more interesting, more appealing. We're more likely to be thinking about it if we're stressed, just naturally. The enteric nervous system may also play a role. That's part of the limbic system. The enteric nervous system is a complex of nerves that regulate activity in the stomach. So those experiences we have of feeling sick or having butterflies, and it's thought that perhaps overeating somehow impacts our experience of that ENS activation. I think we've had that experience. If you've ever binged, if you've ever had that experience, it does absolutely lessen that experience of if anxiety lives in your stomach. And the biological impact of overeating as well, both the prefrontal cortex and the limbic system are temporarily less active when people overeat significantly as the body's focused on digestion. This numbing effect of overeating on emotional and cognitive awareness is also called a dorsal vagal activation. Bottom line is your brain shuts down because your body's busy digesting. That may also be part of why we see a higher correlation between significant ACEs and binges being more severe and more extreme. That is more food in a short period of time. Is BED an addiction? And I think it's just important to address this quickly too. Opinions differ. So this is my take on it. My short answer is no. And I'll tell you a little bit about why I say that with some atoms. So the theory really with BED as an addiction is basically one of them is the dopamine theory. The idea being that where food increases dopamine levels, as do alcohol and other drugs, therefore there's some support for it being an addiction. But in fact, what's true is we're dopamine-seeking creatures naturally. So it's not pathological. In fact, it's hardwired. We get dopamine hits from hugs. We get dopamine hits from petting a puppy. We get them from food. We get them from a lot of things. A lot of things give us dopamine hits. That doesn't intrinsically mean something's an addiction. So a lot of when we think about BED as an addiction, a lot of it can be like to sugar or flour. Often it's connected, white flour is often connected to a specific substance around food. But sugar, for example, is not intrinsically a substance using that addiction parlance really any more than a hug from a friend would be. So that's the first concern that I would have with it. For most people with BED, there are other issues: anxiety, depression, trauma histories, lots of unmet needs, because many people with BED take care of everybody, but everybody else first, that drive them to seek ways to feel better. That's not physiological addiction. It's a survival response to deal with anxiety and shame. Additionally, and maybe most importantly here, for me, I think the abstinence model is what we think of when we think of an addiction. So if we think of something as an addiction, we look to some form of abstinence, some way of restricting or stopping that behavior. I think an abstinence model is much like a diet model. And dieting increases the reward value of food and creates that false perception of being out of control when the abstinence is broken. And so I think what works much better is a permission model. And we're gonna talk more about that in just a few minutes. But the effects of deprivation due to dieting are by far and away the biggest contributor to the increased reward value of food. So neither our minds make a distinction between a diet and a famine. So we're going to have an increased reward value for those foods. We're going to be much more likely to go for them. I don't think that's an addiction or a break in abstinence. Any food plan that requires making certain foods forbidden or demands sustained hunger, we will be far more likely to think about those forbidden foods, seek them out, and overeat them given the opportunity. I don't think that's addiction. And the implications for treatment, as I just mentioned, I think are significant. Abstinence versus permission, and powerlessness versus being powerful. For so many of our clients who are trauma survivors, they have had the message forever that they are powerless and that they cannot trust their bodies. I think recovery has to look exactly not like that. So we'll talk about that a little bit more. So what are the best models for treating BED? Allow what makes for a good model in treating binge eating disorder? I think there are a number of things that are hallmarks. So whatever the model is that you might use, what I would suggest is just make sure that it offers or allows space for these ideas. First of all, seeing our clients as survivors. And understanding binge eating disorder as what I call a red badge of courage, and helping clients to develop empathy for that survival value. It's a strengths-based approach. I think it's really important to bring a strengths-based approach to treatment. There are some approaches to eating disorders that vilify the eating disorder, a life without ed kind of lens, and really try to disconnect from and again vilify the eating disorder. And I know that that is very effective for some folks with some eating disorders. So no judgment there by any means. But what I find more often effective for folks with binge eating disorder is that vilification of binge eating actually reinforces the trauma narratives, and it reinforces the shame that comes so often with binge eating. So I think if we're better able to help our clients understand binge eating from a trauma-informed lens, from understanding why that relationship with food makes sense, we go a very long way to empowering them to understand why they've turned to food and why it's so hard to change. Teach curiosity and compassion as core recovery skills. Whatever model you use, I think it becomes really important for clients to be able to meet the binge urge, to be able to meet bumps in the road with curiosity and with compassion. Instead of or in conjunction with interpreting transference, in a psychodynamic model, I like to offer education about the impact of trauma. I think that piece, again, is very important. If you treat binge eating disorder, you treat trauma. So you need to have that background. Okay, let's see. All right. And then, so I think I froze up for a second. And then incorporate the body as an ally. So any of our treatment strategies, any kind of interventions that we use really need to incorporate the body as an ally, not as a problem to be fixed, and help clients learn somatic skills to recognize and lessen trauma activation. We need to help our clients be able to recognize the person and environment is key to healing and resiliency, which means we have to help our clients go out into a world that's full of weight stigma, among other concerns, and figure out how to hold on to their voice and their truth in that space. So no small task, but fortunately there's a lot we can bring to it. So critical components of the change process. As I said a few minutes ago, I think any treatment model must be strengths-based in approach. This means binging and restriction, both, are viewed through a lens of compassion and respect for the adaptation. I work mostly through an internal family systems model. And one of the things that I really like about an IFS model is that it really does allow us to learn how to separate a little bit from the part that wants to go to food to soothe, or maybe another part that wants to restrict in order to make our body more acceptable. And it helps us actually develop compassion and relationships with those parts so that we can help them not have to do those jobs protect those parts in other ways. So it's really very much a strengths-based empowerment model. So I like that one very much. Also feminist psychodynamic, certainly trauma-informed. So those are just a few possibilities. There are many others, but again, I think as long as they allow for those other components. Models that suggest, and as I mentioned this earlier, this is more of an abstinence model. Models that suggest binging is about being powerless should be avoided. So that is abstinence models. I really don't think they're effective, and the research is backing them up. So what we're seeing is extremely high rates of relapse. I think for many of our clients who are trauma survivors, the idea of abstaining from binge eating, especially at the beginning of treatment, is actually contraindicated. Often they need that relationship with food early on to help them feel safe enough to begin to take some of the bigger risks in doing trauma work. The choice to binge must belong to the client, no behavior contracts. Right. I think it's really important that we're not setting clients up to say, okay, I'm not going to binge this week, or I'm going to do better this week, or here are my binge goals this week. Stuff that's more behavioral. I think that actually has the real potential for setting a client up to continue those shame narratives, particularly if they get triggered around the trauma and they're not quite ready yet to confront that piece of the work. Binging has to be seen as a part of the journey of healing, not as a relapse, which is another reason I think an abstinence model is really not workable. Recovery is not clean, it's messy, right? And sometimes going back to coping mechanisms is going to be part and parcel. The most important thing in that situation is to learn from it. I always tell my clients, never waste a binge. Always let's go back and forensically look at what happened, what need got missed in there that we need to come back and address. And the client's relationship with food is theirs. I think we cannot suggest that recovery or a successful therapy means that a client never binges. I don't think that's actually what it looks like. Where the rubber hits the road, for some clients, that is true. They stop binging and they don't binge, and they just don't binge again. And that does, I've seen clients go, many, many years, don't even think about it. For other clients, that relationship with food may need to remain in the toolbox for a long time. And I think it's important as therapists that we're not shaming of whatever that client's journey may be. So again, some more components of that change process. We have to address weight stigma, body objectification, both interpersonal and cultural, right? We have to look at that self-objectification as well as external objectification and help our clients learn how to understand that from a trauma lens. Right? We'll talk about that a little bit more in a minute. Non-diet or intuitive eating models, I think, are really essential. It builds trust in the body and it allows clients to be the expert and owner of their own experience. It's different for every client. Fixing the body, and I'm putting that in quotes, but fixing the body, that is weight loss or shape change, should never be a treatment goal. It may happen, clients' weights change during the course of treatment, but we do not know that for a fact. And it sets up, again, that narrative that our body has to be fixed in some way. Body autonomy should be the goal of best practice. That is helping clients get better and better at listening to their body's cues and responding to them accordingly. And finally, psychoeducation about weight and health is really, really important. There are a lot of there's a lot of weight and food moralizing that happens that we really have to help our clients challenge, or those ideas about thin necessarily means healthy. So I think it's also really valuable to include trauma-informed somatic models, which are interventions that help clients learn to depathologize the experience of being activated or triggered when they're doing trauma treatment, because that happens. That is your system trying to protect you, and learn how to deal with those experiences. Some ways to help clients build the skills to get out of the fight, flight, freeze, fawn states can include things like somatic experiencing, mindfulness, EMDR, and other body-based interventions can be really helpful. And then also for clients with ADHD or ASD, helping to enhance affect identification and tolerance. So those are all very valuable. Some things I didn't include on here also can include art therapies, equine therapy. I'm a horse person, so I found that very helpful in my own work, but that's not for everybody. But if it's for you, horses can help. So So what are some of the components of treatment? And this is the ideal. And I think that's one of the things that we really have to say here out loud is that, we can't offer all of the treatment that people really need to get better in the best way. In a perfect world, we would have access to these things. Individual psychotherapy that's trauma informed, counseling as needed for the support system for the client, intuitive eating support with a nutrition professional who's trained in doing intuitive eating. An eating coach is great. A lot more of this is online recovery community and available for little or free. If you need some resources, please let me know. Maybe I'm sure you have lots of resources available that you know of already. And then BED and trauma informed medical support. That's tough to find. We keep a list of medical professionals who are versed in a weight neutral approach. And then higher levels of care occasionally are necessary. I don't find that happens very often, but it does happen sometimes, especially if there's intensive trauma work or any kind of medical supervision is needed. So I'll just talk a little bit here quickly. And I think I've got about 5 minutes. Is that right?
Yeah, you've got 5 minutes, and then we'll head into the Q&A.
Okay, so I'm gonna talk even faster. So if I can do that. So some healthy eating and exercise myths, we've kind of covered these, so I'll just go over it quickly. We can correctly define healthy eating. That is amount, proportion, types of foods needed for optimal health. We don't know. We don't know what we don't know what the best human nutrition actually is, much less for any individual person. So the body's gonna be the best judge. Healthy eating is the same for everyone. We don't know that. We do not have the evidence to back that up. Healthy eating results in thin bodies. We've covered that. That's just not true. We know the mechanisms of causality with regard to food, exercise, and weight on health and disease. We don't. We know some correlates. We know some things that seem causal. We don't know the whole picture, and we certainly don't know it for any given individual. I'm sure this is information you're familiar with, so I'm going to go over it very fast. We know that the very best way to gain weight is to diet. That's the upshot of the slide. That is the very best way. Dieters may lose weight in the short run, but the chances of keeping it off for 5 years or more is the same as the chance of surviving metastatic lung cancer. It's about 5%, right? You will not keep weight off in a diet. And yet for many of our clients with BED, particularly those in bigger bodies, that's often part of their treatment plan, right? It shouldn't be. Between 1/3 and 2/3 of dieters regain more than they lose. 3/4 to 90% regain at least the amount originally lost within 2 years. And we see these are just a couple of other examples, so you can go back and look at them at your leisure. There are many of them. That's the upshot. If you would like some others, please let me know. I'm happy to send along a long list. So we also know that dieting just doesn't make biological sense. Our bodies do not know the difference, as I said earlier, between a diet and a famine. When we go on a weight loss plan that involves either significant caloric reduction or tolerating hunger for a sustained period, we experience some key survival-based changes that drive us to seek food, right? So we are fundamentally, our body is going against efforts at restriction. Brain chemistry changes with prolonged hunger to make us feel overly interested in food and make foods appear more tempting than normal. When you lose body fat quickly, the amount of certain hormones in your body changes. Most relevant to dieters, the levels of hormones that help you feel full decrease, and the ones that make you feel hungry increase. Your body is driving you to find food. And finally, our metabolic rate slows, and our bodies use calories with increasing efficiency. Our bodies adapt over time to needing fewer and fewer calories. So when that dieter pretty much inevitably goes off the diet and cheats or is bad and then gives up, their body is going to be much more likely to gain weight more rapidly. So that's that dieter's plateau. That if you've been on a diet, you know what that is. What I work with clients on is attuned eating and movement. And basically it's a health philosophy that says that becoming attuned on all levels to the body's needs for food and movement allows for a decrease in food and weight obsession, a decrease in binge eating, and a more peaceful relationship with one's body, regardless of weight or shape. These are just a few of the components. Unconditional permission to eat, to rest, to move. Rejecting the diet mentality and challenging the myths of weight stigma, Honoring the body. What does your body have to say? Learning to connect safely with the felt sense of body needs, leaving morality out of food. You're not a better person if you eat broccoli than if you eat brownie. Discovering the critical nature of satiety. What do you need to feel fed? What allows you to truly feel fed? Probably it's not going to be diet bread and carrots. Probably you're going to need something that really delights you. Food should be delightful. Build body wisdom over time and honor your needs as best you can and allow your body to determine your weight. Again, much of this is predicated on having access to good food, right? And not everyone does. So these are some of the attuned eating and movement invitations. I'm just going to go through these quickly, but basically the upshot is working on shifting rules for eating from external to internal. Okay. From external to internal, and look at curiosity and course correction, and never prescribing behaviors to people in bigger bodies that we call eating disordered and thin bodies. So that's kind of a takeaway there. I've got 2 slides here of assessment questions for you, just things that you might ask to screen for binge eating disorder. There's a whole bunch of them. They're just, some of the things are repeats, but said in different ways. Do you use food to change how you feel emotionally or physically? Do you think about food a lot in your life? Do you have difficulty trusting your body? Do you limit the foods you allow yourself to eat, but then end up overeating those very foods instead? Do you have a history of dieting or restriction to your family members? When have you felt best about your body in your life? When have you felt worst? What circumstances created that feeling? And a few others. This top one sounds pretty obvious, but tell me a little bit about what you hope to change about food in your life. Actually, I found that's a pretty interesting question, more so than you might think, because people tend to have more really what they want is peace. So I often hear them actually saying, I just want peace from this. And that's actually a very powerful starting point and a very powerful way to build an alliance for change. And then, what is a perfect day for you, just to get a sense of what their diet mentality is like? Do you remember a time when food was just normal? Oh, pardon me. And when does that change? What are some things you've tried to change your relationship with food? And then ultimately to be sure to let clients know, binge eating always makes sense. It's never about willpower or personal weakness, ever, ever. Binge eating is actually made worse by dieting. That's actually very validating for clients to realize that there's nothing wrong with them. Their dieting is contributing to that relationship with food. And therapy will help you find out why binging happens for you, and how it may actually have been helpful, and how you might meet those needs in other ways. Bottom line is creating hope. That's really the bottom line. And helping clients to know that recovery perfection is not the goal, and nothing is going to change in their relationship with food until that feels right for them. So basically, in summary, honor the adaptation of binge eating and restriction, work to heal the trauma, so trauma-informed care, learn the body's language, help clients learn their body's language and develop that trust, expose the impact of weight stigma and body shaming, and help clients find ways to challenge those narratives. Food may remain in the toolbox. So watching out for recovery perfection, and challenging roadblocks to body autonomy as best we're able. So that is all I have for the presentation. I think I came in pretty close to the 40. I hope I did.
Awesome.
So let me stop my share here.
Yeah, thank you so much, Amy. That was a wonderful presentation. Really glad you were able to come. I know it's 4 hours later where you are, so really thankful you're able to stay up with us. I am going to open the floor to questions, but we already had some come in, so I'm going to go ahead and start those. But in the meantime, if there's other questions, feel free to put them in the chat, or if you want to ask your question yourself, you can raise your hand and unmute yourself. But I'm going to go ahead with our first one. So we have Jenny asking a question for you, Amy. She would love to hear your thoughts about the use of stimulants for binge eating disorder like Vyvanse, especially when comorbid with ADHD. So got a good question from Jenny.
It is a good question. Yeah. I find if the ADHD is present, Vyvanse can be helpful, but if Vyvanse is being used as an attempt at weight loss, we're reinforcing those narratives. I also find that many times for clients who are anxious, the Vyvanse, it actually makes them tend to feel more anxious. So I also have a lot of clients who kind of go into taking Vyvanse with that hope of weight loss. So I think if there is a client who's taking it for ADHD, we have to be really careful about those expectations around weight loss and managing those body nerves.
Great, thank you. We had another question come in from another Jenny. Do you have some favorite interventions for helping to change the shame narrative that you mentioned many clients have?
Yes, lots of them, but probably don't have enough time. But let me just suggest a book, if I may. Can I do that? Is that okay? Okay. The book is called More Than a Body, and it's by twin sisters. Their last name is Kite, K-I-T-E. They have some wonderful interventions. The book is for lay. Yes, it's right there. Thank you for holding that book up. That's wonderful. That's exactly it. And they really, I think, do a wonderful job. Also, Christy Harrison's book called Anti-Diet is another one that has some really great interventions for clients, things to try, to explore what it would be like if they, just some exercises to think about what it might be like to shift some of those narratives and to take some of those risks. Again, a lot of working on that is also working on the underlying trauma. Because for many clients, the way that they felt safe was to try to make a body that they think is the body they're supposed to have. So there can be a whole lot of things in there that are going to be woven into the deeper trauma treatment. But just in terms of exercises, those books are very
Great, thank you. We had another question from Claire. For individuals transitioning to a brand new location with no support system, how do you encourage a client around setting boundaries and conversations with new friends on the topic of food?
Oh, yeah, that's a fun one. So one thing I think about is always keeping in mind that working toward body autonomy, working toward body positivity, some people like that term, some people don't, but really is cutting edge in many ways. So most people are not yet on that path. So you're going to have a lot of folks around you, especially if you don't know them well enough to say, hey, could you not talk about this and set that boundary right away? So you might have to get to know them a bit more. But I find actually people are receptive, because if they know that being careful about how they talk about food and weight is actually a way to care for you, is actually a way to be in friendship, they're happy to do it.
Well said. We have another question from Grace. She notes that you opened with saying that binge eating disorder is primarily about restriction. Can you explain that a little bit more?
Is also about restriction. If I said primarily, I misspoke. Definitely, there are binge eating disorders that folks have binge behaviors and don't restrict, but that's actually pretty rare. Much more often, people have significant histories of dieting. For people who have BED and trauma histories, typically the binge behaviors preceded dieting. So the binging was actually earlier. And for folks for whom there's less of a trauma history, the dieting may actually be more causal.
Okay, great.
Mhm.
This is a question from Margaret. Do you have comments about the additional layer for teens or younger individuals who may not have control over grocery shopping or what is prepared for dinner?
Yeah, there's raising, help me with this title. I think it's called Raising Confident Teenagers, or Raising, if anybody knows that title, I'm happy to send it along if not. But it's a book, you think I know the name of it by now, but it's a book that I suggest to parents, maybe who really aren't sure about how to best help their kid to learn how to eat. And to understand that relationship with food is medicine. Learning how to help their kid feel more comfortable in their body and how to feed their bodies well really is the core of recovery. So helping them to really, without shaming, understand.
Is it Raising Confident Daughters? We had another Amy suggest that title.
That is it. Thank you.
Okay, perfect. There we go. Raising Confident Daughters is the book. All right. I don't see any more questions right now in the chat, but if there's anyone else that has questions, please put them in the chat, raise your hand, unmute yourself, introduce yourself. If you unmute yourself, we'd be happy to hear from you. All right, we have another question in our.
I'll have one question. Amy, can you talk a little bit about, we have a lot of providers that have joined us tonight that are really interdisciplinary. And sometimes as providers, we can be on a team of professionals where there may be conflicting positions and views. Can you talk a little bit about how providers can maybe help to advocate for their clients struggling with binge eating disorder if another one of those clients providers maybe is less aware, undereducated around it?
Sure. Yeah. One thing I find sometimes is like, because that happens a lot. Maybe you're with somebody whose education has told them that, that you can't be in a bigger body and be healthy, or that, weight loss is absolutely possible by dieting. And they don't really know the data. So one thing, if it feels like they're open to that data, I just really try to say, hey, I'd love to share this information with you. I know your lens is really different. My lens is trying to help people have a relationship with food that doesn't involve binging as much. And typically they'll jump on with that. And I can say that's an entry point. And I can say, okay, since we're in agreement here on that, here's what the data tells us about what makes binging more likely and what makes binging less likely. So we don't have to argue about weight loss. We don't have to argue about diets. We can just say what we know is that dieting, there's lots of studies that tell us that. So that's the good news. There's a good body of evidence. It is evidence-based to say that dieting makes binging more likely. What makes binging less likely is eating intuitively, is helping clients learn how to listen. So I think we don't even have to kind of get into a feud in that way. We can just sort of say, okay, just for this little population of folks right here, nothing else, this won't work, but this will.
Great, thank you. And I saw Dr. Evans, you had your hand raised. Go to unmute yourself and introduce yourself and your question.
Sure. Hi, Yolanda Evans, she, her pronouns, adolescent medicine physician. And I was going to ask a similar question to Katie Bell, but I'll switch it up because one of the experiences that we've had in our clinic is often the family members with good intent are body shaming, giving value to food, doing a lot of the things that you've talked about as the don't do, or reinforcing myths, and just how to start helping them recognize those behaviors.
Absolutely. Yeah. And I think it is an uphill climb. This is, right, as we know, this is a big job, right? Because we're essentially kind of trying to get people out of a cult, right? I mean, there's so much brainwashing and so much, just like this is the truth. So we're really trying to help folks. So get out of something like that. So what I find is actually really useful is talking more about it from the standpoint of shame never begets change. It actually makes it much harder for people to change because they feel bad about themselves. And if they feel bad about themselves, they're not very likely to take good care of themselves. We're all on a team here to try to get this person to feel better about themselves so that they can take better care of themselves. And I even leave that better care of themselves nebulous for the time being. So in order to do that, what we've got to do is help them to feel really good about their bodies, to help them trust their bodies, to help them learn about their bodies. This is really different than the standard approach might be if your child didn't have an eating disorder. This is real different. And I try to just kind of give it that, because that creates a little space in there, like, oh, okay, well, I'm going to break some of the rules because this is an eating disorder. Okay, right. As they kind of move along, what I find is that people kind of go, this kind of maybe applies to me too. So it broadens. But I find that's a little bit of a way in, is talking about it more in that shame framework, that shaming or trying to control actually will backfire. So let's try some other strategies.
Thank you. All right, we're going to get two more in. A quick one from Christine, looking for some clarification. Can you reiterate what you thought about diets preceding trauma, just to clarify that?
Sure. Yeah, so for the few studies are suggesting that, there's actually a couple more in the pipeline, but that for folks who have high ACEs, basically, binging, the development of the binge behavior tends to precede dieting, right? And for folks with fewer ACEs, dieting actually precedes binging. So dieting is more causal. So basically, what the upshot of that is, folks who have more significant trauma histories are going to be more likely to develop a relationship with food that's about soothing, and then perhaps gain weight, and then the body shaming starts, and then they're going to be more likely to try to diet. Whereas folks who have less are less likely to have to go to food to soothe because that trauma is less, or their trauma may be more purely one of weight stigma and diet culture.
Okay, thank you. And then our last one, from Jenny, curious about your thoughts and experiences on treating youth with body dysmorphia and gender dysphoria and any resources, particularly in the context of living with non-affirming family members.
Oh, whew. I have to say, I don't have a lot of experience truly in dealing with that. I just have to say the truth. I don't have a lot of experience in dealing with that. I know that the book that I recommended, More Than a Body, they speak to that to some degree in that book. So I think that's valuable, but I can't speak to it too much, other than to say that I think, again, a lot of the interventions are ultimately going to be about body autonomy, building body autonomy and body trust.
And one of our hub members, Dr. Melissa O'Neill, also made a note in here, and I'll read that aloud for everyone, that she's found family, however the client defines their family piece, to be essential in the recovery process, and we, providers, must support their needs, educate misunderstandings, etc. as well. So that's the most recent comment in there.
Absolutely. I love that. I love that. I find because parents usually are, and family members and people who care, they're so frustrated because they don't know what to do, and they know that the tools that they have are not working. But this stuff that we're talking about is not common knowledge. So I find when I offer this information, they're just like, tell me more, tell me more. So not always. Often.
Perfect. Thank you for all those wonderful questions, and really good dialogue. Now I'm going to pass this over to Katie Bell to introduce our case presentation.
Thank you, Becca. Our case presentation